platform last night, so I'm a little gun shy here. I woke up this morning and I was talking with my hangover, and just wanted to thank those of you who talked me into going to the tap-in bar last night to see Dr. Bott perform. Thanks a bunch for that. I think they're calling it performing. So we were watching Dr. Bott perform, and I was sitting there and I was just thinking that this must be how a little kid feels when they walk in on their mom and dad doing it. And there's just some of that shit you can't unsee. So Kevin asked me to talk about anterior cruciate ligament reconstruction, and you know, there's like 4-volume sets written on anterior cruciate ligament reconstruction. So what I decided to do was to do just a very basic overview of anterior cruciate ligament reconstruction and just kind of let you know how it's changed over the last 25 years as I've seen it. So I'll try and stay on time, and I know we have some impending weather, so we'll go through that. So let's start with the anatomy. Before we can understand the pathology we're going to try to correct, we have to understand the anatomy. Very basically, the anterior cruciate ligament was one of the main 4 stabilizing ligaments of the knee. Cruciate means cross. It originates on the medial aspect of the lateral femoral condyle, and it inserts on the tibia on what we call the tibial footprint. The blood supply to the anterior cruciate ligament comes through the middle geniculate artery. This is just a arthroscopic picture here. Here's the anterior cruciate ligament coming up. It originates again on the medial aspect of the lateral femoral condyle, comes down and attaches on the tibia. Here's the PCL right here. Now we're looking into a notch. This is the posterior cruciate ligament right here. The ACL should be right up here, again, originating on the medial aspect of the lateral femoral condyle. We can see that it's gone. Basically, the fibers are torn. They're down here. They are scarred down. And again, this is what we refer to as an empty notch sign at the time of arthroscopy, and of course that's pathognomonic for a torn ACL. Bird's eye view of the tibia, what we see is that this is the medial meniscus coming around here and attaching right here. This is the anterior horn of the medial meniscus. The lateral meniscus comes around, attaches here, and snuggled right in between the two is this footprint-shaped area where the ACL attaches. The anterior medial bundle sits right here. The posterior lateral bundle sits right here. So again, the anterior cruciate ligament is made up of 2 bundles. The anterior medial bundle, it shortens from 0 to 30 degrees of flexion. From 30 to 70 degrees of flexion, it's at its baseline length, and from 70 to 120 degrees, it lengthens. Essentially, the anterior medial bundle is tight in flexion. That's the take-home message. Posterior lateral bundle, longest in full extension, tight in extension. That's the take-home message. It progressively shortens with flexion. It's shorter than the anterior medial bundle, and it's larger than the anterior medial bundle. So as we look at this, again, what we're focusing in here on is the medial aspect of the lateral femoral condyle. You see this little half-moon shaped area. That's where the ACL originates from. And as we look at this on the far right, we can see that from A to A, that basically is the course of the anterior medial bundle of the anterior cruciate ligament. So who gets an ACL tear? There's 100,000 new ACL injuries every year, and I would like to reconstruct every single one of them, personally. 1 in 3,000 will suffer. 1 in 3,000 people will suffer an ACL injury in the course of their lifetime. 70% of those will occur during sporting activities. 1 in every 2,000 skiing adults will sustain an injury to their anterior cruciate ligament. So I'm just waiting for Dr. Pierce. So tell him not to eat when he goes skiing, so we can get after him right away. This is one thing that's changed a little bit here in my practice, that depending on who you read, women are at a 4 to 6 times higher injury rate of their ACL. It used to be like 9 or 10 times higher when I first started my practice, but through understanding why some of those things were, they've been able to educate women athletes, and they've been able to avoid a bit of that. So why do they tear more frequently? There's a tendency towards an increased quadriceps to hamstring ratio in women, and that can be addressed. Landing patterns, women have a tendency to land with their knee in full extension or in recurve bottom. That's a very unforgiving position to land in. they land and they pivot and they just pop their ACL. There's a tendency towards a greater hip adduction moment. There's a greater Q angle. There's a tendency towards a increased valgus alignment to the knee. There may be a hormonal influence of estrogen. The ACL is smaller in size than notch width is narrower in size, and there's a tendency towards an increased general joint laxity. So the patient that tears their ACL, they typically present with a low energy injury in sports. That's the most common. Non-contact injuries are more common than contact injuries. 33 to 90% of patients feel or hear a pop. Greater than 75% of patients with acute hemarthrosis basically have an ACL tear. So when I'm teaching medical students and residents, I tell them, gosh, when you have a patient who's participating in a sport, they sustain a loaded twisting injury to their knee, they feel or hear a pop, and they develop swelling within 24 hours of that injury, that's an ACL tear until proven otherwise. Physical exam, very quickly. Observation, acutely they'll have swelling. Palpation, you'll feel the effusion. Dr. Ray Gruby, one of my former partners, I didn't learn this in my training. Dr. Gruby was kind enough to teach me this, that patients have pain in the posterior aspect of their knee joint, basically right over their PCL. I don't know if that's the middle geniculate artery that's causing pain right in that area or exactly what, but Ray pointed it out to me, and sure enough, as I went through my practice, I've seen that patients that have a torn ACL typically have pain directly in the central portion, posterior portion of their knee. Range of motion, of course, is limited because of their effusion. We can talk about Lachman, drawer, and pivot chip testing. So, most of us know what a Lachman exam is. In my mind, this is a 30-30 test. You flex the knee 30 degrees, you externally rotate the knee 30 degrees. Again, when I'm teaching residents and medical students, this guy looks like he's got a pretty heavy grip on this. It looks like, everybody wants to grab the knee and pull on it. They want to pull with their arms. They want to squeeze it hard. The harder you pull, the harder you squeeze it, the more you lose the tactile sense in your fingers. This is a very subtle test. This is a very easy test. When you're performing a Lachman exam, I am holding this just enough to support it, just enough to hold it at 30 degrees, and it's a wrist test. It's just a subtle wrist test. It's not arm, it's not shoulder. And so you're checking two things with that test. With the Lachman test, you're checking translation and endpoint. Another thing is it's hard to get the patients to relax. A trick somebody taught me along the way is make sure that your patient always has their head back on the pillow and have them put their hands flat on their tummy. When you do that, almost every single time, that patient will relax enough that you can get a good Lachman exam. Drawer exam, I don't do it very often because a Lachman exam is much more sensitive. Again, with a Lachman exam, you're checking translation and endpoint. With a drawer exam, you're really only checking translation. The pivot shift, basically what you're doing, you have the knee in full extension. You internally rotate the foot. The ACL is important to prevent translation, but it's also important in rotation. When you rotate this foot, you sublux the tibia. Okay, you apply a valgus force, and as you flex the knee, you'll get a popping sensation as that tibia winds up reducing back to where it should normally sit. So you'll feel a pop or a clunk, and that's what's referred to as a pivot shift test. Now, when you have an ACL tear, you don't always just injure the ACL, you can injure posterior lateral structures, so that's where a reverse pivot shift test can come in. Checking when you hold the leg out in full extension, checking recurvatum. If they have more recurvatum on one side than the other, they may have injured posterior structures in their knee as well. So once you feel that someone has torn their ACL, you can image the knee. The gold standard of imaging is the MRI. What we see right here is the ACL right there. Shows up really very well. Again, originating from the medial aspect of the lateral femoral condyle, coming down and attaching onto the footprint area of the tibia. And here on this view, you can see that this ACL is torn and it's flopped back. There's the PCL. Clearly, these fibers should be coming up here and attaching right here on that half moon shaped area that we looked at previously. So conservative care versus surgical intervention. This has changed a little bit in my practice. Now, I'd like to think it's because society as a whole has changed. Maybe it's because I'm getting older, but we're reconstructing patients that are older all the time. And I think that 55 is the new 35. There's lots of patients that are 55 years old who are triathletes. There's lots of patients out there that are riding mountain bike. There's 65-year-old patients out there that are downhill skiing 125 days a year. So I don't think age is important. It's their general health that's important and their symptoms. So this is really what I concentrate on, including the health of their knee. If it's not an arthritic knee, if they're having symptoms of instability, then a lot of times we do wind up reconstructing patients' knees. Now, when I started my practice 25 years ago, if you told people, hey, we are routinely reconstructing people's ACLs who are 50 years old, that was kind of heresy back then. So more and more common in patients that are a little bit older. We need to make sure, of course, that the patient has the ability to conform to the post-op regimen. And what's the patient's expectation? I take care of patients that say, you know, I tore my ACL playing volleyball, but I'm not going to play planning, cutting, twisting sports anymore. I'm just going to avoid that. So that all those things come into play. The important thing to remember is that this isn't cancer, okay? That it's the patient's choice, really, in terms of what they want to do. Again, surgical patients, a lot of those are easy. Almost every high school student I see gets their ACL reconstructed because they want to return to planning, cutting, twisting sports. Again, age rather than age. I would like to see general health there rather than age. Laxity, when you do a KT1000 and you see someone, even if they aren't having laxity, but they have 9 or 10 millimeters of translation side to side, you can look in your crystal ball and say, I'll bet you're going to have trouble. Meniscal tear. If someone has a meniscal tear that you're going to repair, studies have shown if you take them to the OR and you repair their meniscus, but you don't fix their ACL, the chances of that meniscal repair failing is over 50%. Okay? So typically if you're going to repair a meniscus, we fix the ACL. If you have a dual ligament injured knee, we typically fix the ligaments. So we have graft choices here. I'll just try and be brief here. Bone patellar tendon bone is still the gold standard, 25 years, still the gold standard. It's a strong graft, and we get bone-to-bone healing. So when you wind up putting that bone tunnel, you fill that bone tunnel with a bone plug, and then we put a screw in next to it. It's a wedge-shaped screw. There's very little chance for graft migration. The downside to a bone patellar tendon bone graft is that there is an increased risk for anterior knee pain. There's an increased risk for chondromalacia, and I have seen that in my practice. I have patients, I reconstructed their ACL with a bone tendon bone graft. Things went great at the time of surgery. The back of their patella looked great. We wind up in a situation that they come back 3-4 years later and they've got some breakdown of the cartilage behind their kneecap. We take a piece of bone from the kneecap, so there's a risk of patella fracture. We do take the middle third of the infrapatellar tendon, so there's a chance that that tendon could rupture as well. I've never seen this before. It's been reported in the literature. I've never seen this before either. So quadruple hamstring is regaining quite a bit of steam here. The nice thing about it, it's cosmetic. We can do this surgery through about a 1-inch incision. It's a very strong graft, and there's a low incidence of anterior knee pain. The downside to the hamstring is that we're asking soft tissue to heal the bone, and that takes time. And while that's happening, the graft can move a little bit. If the graft moves, the knee gets loose. If the knee gets loose, then we're in trouble with that ACL tearing again. Allografts, the pros to it, it's faster surgical procedure, there's less postoperative pain, there's no donor site morbidity, they have a quicker return to activities of daily living. The downside to it is there is a risk of transmission of disease. It's about 1 in 1.6 million, so it's very low, but it does exist. The failure rates, there's a study out that shows that the failure rate of an allograft reconstruction in patients under the age of 30 is about 30%, and that's too high. It's a longer revascularization period, and there's cost involved. You gotta buy the graft, and they're not cheap. Quadriceps tendon, I've done this one time. I did this in my training one time. It's a strong graft. The problem is that you still have the risk of anterior knee pain. You still have the risk of chondromalacia. You still have the risk of a quadricep or of a tendon rupture here, and then you have a soft tissue fixation issue on one side. So in my mind, you get the worst of all worlds there with the quadriceps tendon graft. So let's just quickly, we'll go through briefly how we do this. What we see here, this is a torn ACL. We go ahead arthroscopically, we remove the old ACL. Here's the PCL right here. Here's the tibial footprint right there. And again, here is the medial aspect of the lateral femoral condyle where the ACL is supposed to originate from. We go ahead and we harvest a graft from the front of the knee. We take a piece of bone from the kneecap right here, and you can appreciate if you fell on that kneecap, it could crack. We save the bone shavings from the tibia, we stuff them in here, and studies have shown in 4 to 8 weeks, what winds up happening is that that's a pretty solid patella. We take the middle third of the tendon. You can appreciate that the infrapatellar tendon could rupture. Studies have shown about 2 years after surgery that that has reconstituted. So that's what it looks like in real life. So I usually pass the graft on the back table where Brad works with that to fashion it to make sure it passed through a 10 millimeter tunnel or a 9 millimeter tunnel. While he's doing that, I'm drilling holes. We have guides that help us figure out how to get a hole drilled that comes out basically right in the center of that tibial footprint. There's a pin that came up right in the center of the tibial footprint. Again, PCL here, and here we are again at the medial aspect of the lateral femoral condyle. Then we go ahead, we over-ream that, we create a tibial tunnel. There's the tibial tunnel right there. There's the PCL again for reference. We also have jigs and guides that help us figure out how to get onto that half moon so we can get to the origin of the ACL. And we go ahead, we drill a pin through that. We over-ream that. This is another thing that has changed in my practice. We typically do not drill our femoral tunnel through our tibial tunnel. We found out that we were putting our grafts at the 1 o'clock or the 11 o'clock position. We were reconstituting the anterior medial bundle, but we were kind of ignoring the posterior lateral bundle, so we were getting great anterior posterior translation control, but not very good rotational control. So now we're moving this from this 1 o'clock or 11 o'clock position down the sidewall here more towards a 9 o'clock position. So this is just a diagram showing passing of a graft. So this is a bone tendon bone plug going up into the femoral tunnel. And now we're going to get fixation. So you can see that's pretty tight fit there. And then we're going to go ahead and we're going to put a 7 millimeter screw next to it. Now, this is a metal screw. That's another thing that's changed in my practice. We actually have screws now that will actually dissolve or absorb over time, and they'll actually turn into bone. Why is that a benefit? Well, if this person has another problem and we have to get an MRI, we get a lot of scatter from these screws, and it makes it difficult to interpret the MRI, number one. Number two, if this person, heaven forbids, re-tears their ACL, and we go ahead and we have to drill a 10 millimeter tunnel here, and we've got this 7 millimeter screw, we take this out, we've got a 17 millimeter hole here. That makes it very difficult for us to get the ACL in the right spot. It makes it very difficult for us to get good fixation. This is just passing of a graft. Now, this is a staple down here, and this is another staple up top. So one thing that's really changed for us, we have very good fixation now. There's been several different generations of graft fixation that has helped us, specifically with hamstring ACL reconstruction. So graft healing goes through these basic phases. You have an inflammatory response where basically the graft dies, and then it revascularizes over 3 weeks to 16 weeks, weakest at 7 weeks, and then you have this period of maturation or ligamentization, if you will. Graft is strongest probably at about 1 year. So looking at this, these are the screws I'm talking about. This is not a metal screw. There's several different companies that make them, tomato, tomato. We go ahead and we put a screw up in here, and over time, that screw will actually turn into bone, which is fantastic. The other thing I was talking about, you can see how this graft has come down the sidewall here. Rather than being up here at the 1 o'clock or 11 o'clock position and the 1 o'clock position, it's closer down towards 9 o'clock. You can appreciate that we actually drill the tunnels either through the portal here, or we have some flip cut guides that can help us do that as well. So you can appreciate the obliquity of this graft and that it will actually better parallel an anterior medial bundle and a posterior lateral bundle rather than just reconstructing the anterior medial bundle. Fixation has changed quite a bit. You can see this is basically a cinch loop, and that allows for very little migration there. That's a very good product. Almost every company has one similar to that. With hamstrings, we went ahead and we were fixing them initially with staples and with buttons and those kinds of things. They developed a screw. It was a blunt threaded screw that would go in and wedge this in place. It still kind of cut the graft, I think, because our failure rate was still pretty high. Now they've gone to this cinch loop, and then there's a button here that we can put in that actually has a plastic sheath that will help protect it. And I will usually augment that with a hitching post down here. We just put the post here. You can see where the stitches are cut here. I leave those stitches and tie them down around that post. So I just think I'm getting maximal fixation there. And in my practice lifetime, I've seen my re-tear rate with hamstrings drop pretty significantly. Another thing that came about, all I've talked to you about is single bundle ACL reconstruction. There was a double bundle that came on the scene And they had pretty good results. They had some complications. They had pretty good results from the standpoint of what a KT1000 showed us, the difference in translation side to side, but it was a situation that the re-tear rates weren't any different. It's technically more demanding. There was more complication. They actually had fractures through this area. When people would bear weight, they would break into it. The tunnels would converge, and when you put fixation in that, you wound up breaking through from one tunnel into another tunnel. So I think that there are people still doing it, but I think most people in the country are doing a single bundle. And again, I still think that the gold standard is a bone-tended bone graft. So, thanks for your patience. I sure appreciate it. Thanks, Mom.
Dr. Carlson, I have a question.
Yeah.
Could you quickly, age 18 to 35
Yep.
versus say a 35 to 50, 18 to 35-year-olds, what percent do you think you do surgery versus they go the conservative route? And then that 35 to 50, what percent of those folks get surgery?
So first of all, totally their choice. And it's totally based on their choice and their symptoms. And you know how it is when you're talking with a patient, you think, gosh, I think I can help you here. So I would say up to 35, it's got to be 80, 90%. And then older than that, I would probably say it's at least 60%. But if you said to me, what percentage of patients that have good articular cartilage and are having symptoms of instability, farmers, ranchers that are out saying, hey, I got to be careful of a bull charging me, and I have to get up on this equipment, and it's muddy. Guys that work at the mine, where they have to go out and work on equipment in the mud, it's probably up to 90% for people that have instability. They say, gosh, I can't trust this knee, I can't work on this knee. So, yeah, lots of them.